Welcome everybody. Let me open the public board meeting of NHS England. First of all, we have some apologies for absence today. Emily Lawson and Simon Wesley, Jeremy Townsend, Mark Walport, Mary Watkins, who was with us this morning in the private board session, but can't be with us this afternoon, and also Tanuj Kapilaswamy. Are there any new interests any members of the board need to declare? Thank you very much. Can I take the minutes of the board meeting held on the 25th of July? Can I approve those?
Yes.
Thank you very much. Let me just very briefly provide a sort of a chair's update on recent activity. First of all, actually, I should start by saying that it's absolutely great to be here in Blackpool for our latest board session. We hold 2 or 3 boards in the year outside London, and our last board was in Norwich, and today, bless you Amanda, today we're in Blackpool, and we're absolutely delighted to be here. I'd like to thank our colleagues from the North West Regional Team and the Lancashire and South Cumbria ICB, not only for helping with the arrangements, but actually for hosting us. And we're very pleased to have Kevin Lavery, Chief Executive, and Dr. Andy Knox, Associate Medical Director from the ICB, here with us, and to discuss actually later on in the agenda integrated care. And actually, just to share, that was very much a focus of a visit that you kindly arranged for me yesterday when I went to the Whitegate Health Centre. It was a brilliant visit, actually. I don't quite know how to describe it. I think I said to you, it felt like it was like a sort of a mini hospital for minors. And actually, Amanda Doyle here corrected me and said it's actually more a hospital without beds. And the reason for that, actually, is I had no idea that there was so much provision of so many different services in that location. And it was a sizable building, 3 stories, and of size, modern, which was great to see, but urgent treatment centre, sexual health care, dental services, community diagnostic centre, offering MRI and CT and other diagnostic capabilities, podiatry, children's mental health, adult mental health, and other services. So I was it was a brilliant thing to see, and it made me think, actually, if that's is that the polyclinic model that was talked about some years ago? But congratulations to those who conceived it and built it, actually, and it was a brilliant visit. Now I know the board, actually, so what we tend to do when we hold board meetings outside London, of course, is actually the day after the board, the directors then split up and go and visit various parts of the system. And tomorrow we're doing that as well. And we're going, I think there are 5 different visits around different parts of the system. And that's a really helpful sort of learning for certainly the non-executives and perhaps the executives as well. But also, actually, it's an ability to communicate and to hear directly from people right on the front line, and here particularly in Lancashire and South Cumbria and in Blackpool. Let me turn to some housekeeping. I'd just like to start, to her embarrassment, no doubt her embarrassment, by thanking Professor Dame Helen Stokes-Lampard, who, as we know, will be leaving us pretty imminently, actually, to go to the other side of the world, to become Chief Medical Officer for Health in New Zealand. And even though Helen joined us for a relatively short time, she's been absolutely pivotal, and thank you for it, in our work on both primary care and on our quality agenda. And of course, you've also been a force for good within the NHS more broadly for many years, both as a GP for your community, as well as chair of the Academy of Medical Royal Colleges during 2020 to 2023 through the COVID-19 pandemic. And also in your previous role as chair of the Royal College of General Practitioners from 2016 to 2019. Helen, you are an amazing person and an amazing medic, and we wish you huge success in New Zealand, and the leadership you've shown in your role here and more broadly in your career, I know you'll continue. And that's to New Zealand's great benefit. So many thanks. Just a series of engagements, if I might share with you. So I went on a very good visit to St Anne's and Chase Farm Hospital as part of the North London Mental Health Partnership, and it was very good to again engage with frontline staff to see, in particular, actually how proud they were of the accreditation that St Anne's had received. And it was also most interesting to see how Crisis Hub actually worked and operated. It had been explained to me, but to see it in action and to see the pressures on it and how those challenges and pressures were dealt with was really sort of informative and helpful, and how they're there to support people in mental health crisis, but also actually assisting police forces reducing detention. And that's clearly something very relevant to the paper we'll be discussing later today, I think, on community-based support for people with serious mental illness. I've had a whole series of different meetings, so with colleagues obviously from the department and from other arm's-length bodies, and also meetings with Confed and with providers and with the Assembly, with the Health Foundation Chief Executive, with a group of chairs from mental health trusts, as well as actually the quarterly meeting with all the ICB chairs. So we do 3 meetings in the day, so 42 ICBs split into groups of 14, and that's a really helpful engagement. And then we've had 2 Genomics England boards where I sit on the board for the NHS, and also on Monday I chaired the Genomics Medicine Services Board. Again, I raised that because there was a very good announcement this morning, and Steve Paris, where are you, Steve? Congratulations on you're on the Today programme again. You're quite often on the Today programme, but I thought you covered what's a really very good announcement, a very good step forward brilliantly, and it's the announcement of the new generation whole genome sequencing. And so now actually working with Genomics England, the NHS, I think through 13 or 14 hospitals and going to grow to about 40, has now tested so far 500 babies, so newborns, and we're testing whole genome and scanning for 200 rare diseases. And actually, if one thinks about the way genomics will play in the future model of healthcare, this is, again, a brilliant step forward, and I think demonstrates the continued innovation that we see in the health service. On some of the work of the board, this morning we did discuss in the private board Lord Aradarz's very good report. I'm clear, and as I know Amanda will say and has said publicly, it's a very challenging report, but one which actually shows the significant challenges that the NHS is dealing with that many of us actually recognise. We also had 2 good sessions as a board in the past weeks with Sally Warren and her colleagues as she brings together and starts to construct the plan for the 10-year health plan. And we're also looking forward to engaging with that much more as that continues to evolve. We had a strategy board about 3 weeks or so ago, and it was to that board that Sally came. That was for one of the engagements we've had with her. But we also discussed the health and work agenda. And that obviously ties in with the announcement that the Secretary of State made last week on focusing GIRFT support, so get it right, first time support, in areas with higher numbers of people who are economically inactive. But it's clearly an area where there are clearly many more opportunities for the NHS to contribute to the government's growth mission. And on top of that, we had, as the board knows, a training session, a very good training session on patient safety for senior leaders, and taking us through what board colleagues all across the NHS need to know and look for so that they can get on top of problems early and hopefully head them off. Now, safety is something we often talk about here. We did again this morning in an update led first by Robert Leckler, thinking about the quality committee and the quality agenda, and also Amanda looking at how we put quality at the pivot or the keel of NHS strategy. So safety is something we talk about often and can take many forms. And actually, Steve, I do just want to pick up one, which was the Pediatric audiology story that ran across the last weekend's newspapers as just one example. And I know you and Sue Hill have been working on this for some time, and you might want to give us some perspectives just on that.
Yes, happy to do that, Chair. So first and foremost, important to say we understand just how worrying it must be for parents to learn about the challenges within paediatric audiology services. And I know that for those directly impacted, this will be an incredibly distressing time. And to them, of course, we extend our sincere apologies. It's a very serious issue, and we've been undertaking, as you've said, extensive work to address it as a priority. The issues first came to light because following concerns identified in audiology services in Scotland, we undertook our own review into hearing data for every baby born in England from 2018 to 2023. And this identified 5 services where significantly fewer babies had been diagnosed with permanent childhood hearing impairment than we would have expected. And then further analysis of these services identified a number of concerns that suggested there could be more widespread quality issues. So in response, last year we established the Pediatric Hearing Services Improvement Programme under the leadership of Dame Sue Hill, as you said, the Chief Scientific Officer for England. And the programme board which supports Sue and oversees this work includes providers, includes NHS regions, multidisciplinary experts, professional bodies, and importantly, patient groups. And a year ago, we wrote to integrated care boards, who are the commissioners of these local services, asking them to assess their services against a set of national recommendations. And where services did not meet these recommendations, we additionally asked ICBs to take immediate action to implement the necessary changes. Since then, all 140 NHS paediatric audiology services in England have been assessed. This work, which concluded in early August, has identified 90 services where we currently have insufficient assurance of the quality of services being provided. And these services will be now subject to further in-depth expert reviews, including determining where children should be called back for reassessment. And we wrote to ICBs once again last week with detailed guidance on this next stage. Now, centrally, NHS England will be providing support to local commissioners by providing additional central funding for senior scientists with audiology expertise to provide expert oversight and input into the reviews. And this will also ensure that tests for patients are carried out as quickly and safely as possible. And in parallel, during the last year, we've held national and regional learning sessions for clinical staff focused on driving forward major improvements in professional standards and testing techniques. But we understand the need to move at pace, and so the national aim is to complete all patient reassessments that arise from this process by March 2025, and to ensure that all patients are either discharged or placed on an appropriate treatment pathway by September 2025. And we also understand this is a challenging time frame for our ICBs and local services, but we also recognise that particularly for children, hearing issues need to be identified early, and we know that this wait will feel unacceptably long for many. We also recognise concerns about the impact that this additional work may have on those awaiting audiology services, and we are working hard to minimise any impact. And while the NHS continues the review process, we're also working to ensure that this never happens again. Frankly, we need to future-proof England's audiology services for patients and for their families. And this, for example, may include potential reconfiguration of services to ensure they're more resilient and more sustainable, a greater focus on quality and accreditation, and greater standardisation of training. All this work is complex, changes will take time, but we're committed to driving improvements in these services, and I'd like finally to thank all of those who I know are working incredibly hard at both national and local level to address the challenges that we see.
Steve, thank you for the update. I think it was important to reflect on that, and not just because it was covered in the news, but actually I hadn't realised that was the situation. And thank you for the insight to the work that's ongoing now and the urgency with which it will be pursued. So thank you. I have referenced the 10-year plan. And again, we discussed it somewhat in the private board this morning. And we're not the authors of the 10-year plan, but we clearly have a major contribution to make to it as essentially the delivery arm for health in the country. And I, musing with Amanda, would hope that a number of the things we've talked about over the past months, which we would call our main priorities, I would sometimes call them the enabling priorities, of what would feature in the 10-year plan as we look forward, including potentially the considerations of how the offer of health service, the model of care may well change as we think hard about the impact of technology and changing skills, as well as changing societal demand. But are there different models of care? And I would hope that that is very much a feature of it, along also with, if I thought about some of the areas we've been very strongly engaged on here, the long-term workforce plan, really important. We had a conversation a couple of boards ago about the long-term infrastructure strategy, which you could call the long-term capital plan. I mean, it's the equivalent of the long-term workforce plan. And clearly, actually, one of the things that our Lord Darcy pointed out was capital underinvestment, and we've clearly done a lot of work. It's a very strong forensic foundation, an audit effectively of the current state of our estate and our technology and our diagnostics, and clearly has good information and direction in it. We've talked about capacity, both primary but also secondary, and whether we should think about capacity, in a way I would call thematically. So you can't just think capacity, how do I build more, but you can think about how is the current capacity we've got being utilised, and can we therefore tilt demand, shape demand, so we utilise that capacity in a different way. And that leads to things like the pilot that is ongoing at the moment, a very good pilot on frailty. Frailty tends to be linked to older people, but frailty. And also the very good pilot, which I hope will be a feature in the 10-year plan around primary care, where again NHS England is doing a very significant piece of work. The other area is just to reference. I would hope that the continued rollout and devolution to the ICBs continues, even though we do know that current performance is variable across a range of measures. But actually the idea of devolving close to the community and then working across the boundary into local authorities, social care, and into the community is a very, I think, helpful direction that the board wholly supports. So continuing to support that and to help shape it to be more successful would feature. And then my last two, which I think are really important, and Darcy captured one with I think it was called the tilt to technology or some such phrase, but a very good reference, just on how powerful technology is going to be, and actually how do we think about that in terms of properly architecting it, and then what choices we make in no doubt a constrained environment about which technologies at which area of the system do we prioritise for investment. But the role of technology in changing health provision must surely be a very strong feature of the 10-year plan. And then lastly for me is just innovation. And referencing that announcement this morning about the new generation, newborn whole genome sequencing announcement, that innovation, or the cancer vaccine launchpad, or the bespoke or tailored vaccinations, I think, for lung cancer and bowel cancer, or just actually the way we use genomics today, going back to that example. So 700,000 patients tested last year for whole genome or panel or single tests for 200 cancers, 7,000 rare diseases. What a remarkable world. And actually the forward innovation that I think we can see, I think must be features of the 10-year health plan. Now, I just want to round off on the topic of finance. Julian is joining us, hopefully imminently. He's been caught up in another and really quite important, obviously, discussion, and he'll cover the financial position. Look, suffice it to say, as we know, the picture is very challenging, and it's very challenging across the service and across the systems. And it's not for the want of effort on the part of people here, the board, the executives, NHS England, or colleagues out throughout the systems in the NHS, that we do face a very difficult and challenging financial picture. Now, the fact that spend on agency staff is at its lowest ever, so it's lowest on record, again, is a testament to the focus and work on that. And that's at the same time as activity continues to grow and remains at record levels in many areas. And that record level of health provision that we're seeing today, the NHS provides record levels of healthcare, absolute record levels of healthcare. It's a testament to how hard people across the system are working and to make taxpayers' money go as far as humanly possible. But what I want to say, I've read a lot of commentary this week from the system on the financial position and how difficult it is. And I hear that. We hear that, and we understand it. But I would add that there is no one here at the board, or indeed at NHS England, that doesn't recognise the reality of that challenge, and that we've been consistently transparent about the very significant financial challenges we face. But I would also add that the government has the very difficult job of setting the funding and mandate for the NHS. And it is our role as senior leaders in the NHS, whether that's the NHS England board or senior leaders in the wider system, to fully take on the responsibility for making this work as best as possible within the financial envelope that we have been given. So I was reading some comments. Actually, it's a very challenging situation. We all own that challenge. We all own that challenge, and it's really important that that we face to it. So that's what I wanted to say by way of introductory remarks. And at which point, can I hand to you, Amanda, Chief Executive's update, and then hopefully Julian will be in time for the CFO update. But
yeah. Richard, thank you very much indeed. And look, can I start by just echoing Richard's thanks to colleagues from the region and from Lancashire and South Cumbria ICB for hosting us, and to Kevin and Andy for joining our meeting today. As Richard says, I think we're very much looking forward to having dinner tonight with a wider group of colleagues, and then we've got some great visits to look forward to tomorrow. Also like to add, just to further her embarrassment, my personal thanks to Helen. As Richard said, your time with us, Helen, has been a lot shorter than any of us would have wanted, but our loss is very much New Zealand's gain. And Helen, your contribution to the NHS, to the medical profession, to primary care in particular, means you'll be leaving, I think, with the best wishes of the whole of the NHS, not just of this board. Just while we're talking about people, I know you're aware of this, but we are absolutely delighted to have appointed Louise Shepherd, who is the Chief Executive of Alder Children's Hospital, to the role of Regional Director for the North West, so the region that we're in at the moment. And I would just like to thank again Michael Gregory, who's done a great job in covering that role in the interim since Richard Barker retired. Since our last meeting, an awful lot has happened. And I just wanted to I didn't want to let us have this conversation without just noting that, of course, one of the things that the North West has had to deal with since we were last together were the horrific events in Southport at the end of July. And I would just like to thank all of my colleagues in the NHS who contributed to the care of those children and adults killed and injured that day. And that is, as ever, a testament to the way that the NHS comes together around communities and around patients at the most challenging of times. This won't do justice to all of the colleagues who are involved, but just to name a few, that was North West Ambulance Service, that was Southport and Formby District General Hospital, Ormskirk Hospital, Alder Children's Hospital, Aintree University Hospital, Manchester Children's Hospital, and then, of course, colleagues from across the ICS and from the region. I mean, so many people did an incredible job that day and over the days that followed, whether that was supporting the victims and their families or dealing with the mindless riots that followed. Their professionalism and that of the police, fire and other services deserves our respect, but we also know, and we'll talk about this, I think, perhaps when we talk about mental health services a bit later on, but for some of those individuals, those events really will take a long-term toll. So they deserve our ongoing support, and we have committed to that. Since we last met, We've also continued to work with the new government. We've seen a really welcome focus on engagement between the Secretary of State and the wider NHS, including regional visits and a national meeting with Trust and ICB CEOs. As Richard says, we've obviously been working with the new government on early policy initiatives. Most notably, that included the Further Faster 20 initiative, which the Secretary of State announced at Labour Party annual conference last week. As you mentioned, Richard, that will see a version of the GIRFT Further Faster programme targeted at 20 acute trust-serving areas with higher levels of economic inactivity and whose waiting lists show potential for targeted improvement work to increase activity and to bring waiting times down faster. So on top of supporting the efforts of all systems, which everybody is doing at the moment to speed up waiting times for planned care, that is a really welcome opportunity for the NHS to demonstrate how a clinically led, data-driven, patient-centred approach to improvement can deliver real, wide-reaching benefits for individuals and for local communities and economies. We've also had, and Richard, you've mentioned this as well, but the milestone report from Lord Darzi on the state of the NHS. Clearly, as you said, a very difficult report for anyone working in the NHS to read, but one that those of us working in the NHS, I think, would just say we would absolutely recognise, accept and endorse as a diagnostic of the current performance challenges NHS teams are managing and patients are experiencing, and the drivers behind it. And importantly, it reiterates that the NHS model is the right one, that its greatest strength is its people, that there are many good things that we can point to and build on in the NHS, but to quote, waiting times can and must improve quickly, but it will take years rather than months to get the health service back to peak performance. But if I may, just to put my sort of personal views on the record, I would share Lord Darzi's optimism that despite the extent of the challenge, with the right support, we can return to peak performance, and with the opportunity of the 10-year health plan, together we can make the NHS fit for the future. And on that, so discussions with Sally Warren and her team have continued since our last meeting, including on the shape of the engagement process with staff, patients and the public. Where we can, though, we're obviously continuing to act now to put in place the foundations for the future of the NHS. And as Richard, as you mentioned a couple of times already, the coverage of the Generation Study this morning, which is now well underway. Forgive me for just mentioning it again, but it is genuinely a revolutionary project for the NHS in England, because if we can diagnose and treat children for rare conditions, potentially years earlier, we have the potential to stop debilitating conditions in their tracks. We can find difficult to diagnose conditions earlier, and we can provide earlier treatment. And crucially, that will enable more children to live happy, healthy lives, starting school and living independently. So that is really important news for patients and for families, but it's also important for the NHS because it is another, as you listed out, Richard, example of, where when we are able to work with partners, as we have in this case, we really can cement the good work that we've been doing, and in this case, cement our status as a world leader in genomics. And as we look to the 10-year health plan, we know a big part of it has to be about how we set ourselves up as well as possible to be able to benefit from these cutting-edge technologies that can so dramatically improve patients' lives. I should say, though, while we are always looking to the future, we are, of course, always 1 foot in the here and now and focused on today's challenges. So, Richard, you've mentioned the financial position. Julian will add more on that shortly. But as usual, at this point of the year, the particular focus is how we support colleagues like Kevin and Andy to manage the next few months as well as possible. As I left the house this morning, I did think we really are just beginning to enter winter. I have to say that was very early to get an early train, so it's warmed up a lot since then, but winter is coming, and our winter letter very much put the focus squarely on maintaining quality and safety in the urgent emergency care pathway, as well as delivering our plans on headline priorities, including elective care. We did discuss that in some detail this morning, but Sarah Jane, I know you will cover that as part of your performance report in a moment. Vaccinations are just another really crucial part of our sort of set of things that we know we can do to help people protect themselves and to help protect our staff over winter. So I did just want to say on that particularly, UXA figures out this week show the very real threat of winter viruses. There have been at least 18,000 deaths associated with flu and over 19,500 deaths associated with COVID-19 over the past 2 winters. Today, our COVID and flu vaccines begin, so if anyone is listening to this who is eligible and has not yet booked in, please do so without delay. We've invited over 11 million people to come forward, and it is absolutely vital that we do everything we can within the NHS to make it as easy as possible for vulnerable groups to get protected ahead of winter. So teams across the country are already doing this, and that is everything from sending teams into schools to mobile units in supermarket car parks giving jabs. So I'd like to thank everyone who is involved in that effort. It really couldn't be more important. And also like to add my thanks to those teams who've made the first ever RSV vaccination rollout possible. Our first data, I'm sort of looking at Steve because he is the lead for this, and I'm conscious I might be stealing your thunder when I say this, but our first data shows that the RSV vaccination programme is already off to a flying start with over 500,000 people already protected. The uptake is, however, lower for pregnant women, which is a cause for concern because research shows that the vaccine can cut the risk of severe lung infection by around 70% in the first 6 months of a baby's life. So we will be working really closely, and I'm looking at Duncan here as well, with maternity teams as well as GP teams and other organisations to encourage people to come forward. As just a last point, I want to say thank you to all colleagues who continue to contribute to our ongoing improvement work under the NHS Impact banner. Last week, so I'm looking at Vin and Sarah Jane in particular here, but last week we published the first 4 draft improvement guides, and they cover flow in emergency care, elective surgery, outpatients and medical consultant job planning, and launched regional learning and improvement networks led by Trust Chief Executives. I think we're all clear, and in fact it was in Lord Darcy's report as well, that there is more that we can do and should do to support the many, many people who want to improve operational and clinical pathways and processes and are already doing so. And this initiative is one of the things we can and will continue to do now, whilst those discussions about what we want to achieve in the future go on.
Amanda, thank you. I was just say, given my age, actually, you'll be pleased to know I've also been contacted and I've signed up for my vaccinations, which I'm having on Saturday afternoon. I responded to the message I received. Very good. And I would just also, I just want to also just express some thanks to non-exec colleagues, if I might, because actually since the various organisations came together, so Health Education England and NHS Digital and NHS Improvement and NHSX, actually the workload of the board actually is very significant, and we received updates in this morning's private board from a range of committee chairs representing some of the key points arising in that committee work that had been done since the last board meeting. So we had updates from the Data, Digital and Technology Committee and on the Workforce Training and Education Committee, predominantly driving at delivery of the long-term workforce plan, People and Remuneration Committee, the Audit and Risk Assurance Committee, a very necessary and assurance and governance function for us. Had an update from the Quality Committee from Robert, who's now taken that, and thank you, Robert, for taking on the chair of that group. We also had an update on the CFO advisory group and from the new hospital programme delivery group. And often the work of the board, actually, which happens between board meetings, is perhaps not recognised in terms of the demands that it places on colleagues. So my thanks to all of you for all the work that you're doing. Now, at that point, we're going to move, I think, Sarah Jane, to an operations update, performance update, operational performance. Can I hand to you?
Yeah, you absolutely can. Thank you, Chair. So the report I'm going to share now covers the period across July and August and is obviously based on the published data that's available. Before I go into the updates, I just want to reiterate Amanda's thanks for all the hard work that is going on at the moment. Just there's daily challenges for teams right across the NHS and social care indeed to deliver the standards of care that our patients need and deserve. And at the same time, we're also planning for what we know will be a challenging winter whenever flu, COVID and many of the other seasonal illnesses present themselves. The NHS is working very hard to get ready for that. Each region is actually having a focused session, bringing together ICB and Trust colleagues to think these issues through, particularly the areas that potentially pose the biggest risk in those individual regions, and looking at a range of areas, things like what we can do to minimise handover delays, long waits for patients with mental health conditions waiting to be moved to inpatient care, some of the in-hospital processes and issues related to discharge. So those events have already taken place in London and the South East, and we're looking forward to more of those to follow over the coming weeks as well. We did write out on the 16th of September just to really reiterate that which was already in the UEC recovery plan 1 year on document, just really highlighting the things that can help all systems to prepare for winter, and just again highlighting the good practice and the interventions that we know can make a difference even in really challenging circumstances. And the guides that Amanda has just alluded to really go to support that and further codify the steps that organisations can take. We're also really pleased that since we last met together as a board, the junior doctors have accepted the government's pay offer, which is really great news for everybody across the NHS, but for us in operations, it gives us certainty about our winter planning that was perhaps more difficult for us last year in terms of really being able to shore up our rotas and approach. So I'm going to run through the headlines. I think in all of the areas there are common themes. There are huge challenges. We know the needs of our population. There's some really impressive numbers, but I wouldn't want to give the impression in presenting them that we know that there's not a huge challenge that sits alongside that, and that there's still a lot further to go. And just as Lord Darcy's report makes clear, I think we're all really determined to step into that challenge. So just in terms of UEC performance, in August, we achieved 76.3% for emergency department performance, which is the highest, I think, for around 18 months. It was, again, against a backdrop of increased demand from that which we normally see in the summer. And we delivered a Category 2 ambulance response time of 27 minutes and 25 seconds. So again, that was a significant improvement on previously. We obviously not complacent about that. We always do better in the August period. We know that things have become a little bit more challenging in September, but I think it does prove that when we are focused on our interventions and demand is at a reasonable level, we are able to provide that level of service to our patients, albeit more to do. In terms of electives, the total waiting list increased just for the second time since October 2023, but only a small increase of 1,651 patients. Our main focus has been seeing as many patients as we possibly can, which has absolutely happened. Our activity levels are at a record high, and also focusing on those long waiting patients. We've got the milestone that we're working towards for the end of September in terms of the 65-week waits. So we will report on that at the next board meeting, but everyone across the NHS is focused on that. In terms of cancer, again, we've seen high referral rates, but we've maintain good progress against the standards, and we are continuing to monitor closely. Obviously, the faster diagnosis standard remains that which we keep very close attention on, and that stood at 76.2% in July, which is good performance against the standard. In diagnostics, again, our activity levels are up significantly, and that's in large part due to the community diagnostic centres, which we talked about at the private board this morning. But again, demand for diagnostic services, both in planned and unscheduled care, is also continuing to increase. So whilst we are making improvements against the 6-week wait, the size of the waiting list is growing. So I think diagnostics is an area of focus that we want to really understand moving forwards, particularly some of the growing demands that we're seeing for diagnostics in unscheduled care. And then for mental health, this is June and July data, just based on the way that mental health data flows. The dementia diagnosis rate is at 65.2% as of July 2024, against our ambition of 66.7%. So we've got a little bit further to go there, but it is continued steady improvement since the standard was introduced in January 2023. We've also seen some good improvements in adults completing their course of treatment, and children and young people's access to mental health services and perinatal mental health services, although again there's lots of focus across the regions to make sure that we absolutely deliver to those standards. I think the one area that we are jointly working on between the UEC and the mental health teams are those urgent and emergency care services for mental health patients, where despite all of the efforts to do everything we can to maintain flow across our mental health pathways, we are still seeing too many patients that are having to wait unacceptably long in our emergency departments and in some of our acute hospitals, waiting for inpatient beds to be available, which in turn is often as a result of our challenges moving people back into the community after their inpatient mental health stay and getting them the right housing and social care support as well. So I'll conclude as I started. There's some brilliant work going on across the NHS, some really impressive numbers, but I think we're really aware that for all those patients that we have been able to look after in the way we want, there are big groups of people that are still waiting for access to our care, and we need to remain absolutely focused both on delivering the standards for this year, but also now with an eye to the future to think about how we can continue to bring some of those waiting times down and access for patients across all services in a timely way. Thank you.
So, Jane, thank you. Let me pause and see if colleagues have any comments or questions for you. So, let's go Wal, then Andrew.
Thanks, Chair. So, Jane, thanks. And it looks good. But as we're getting into winter, is it worth just touching on your view of the state of the system as we're going into winter and the resilience of the system? Because I know you and colleagues have been doing a lot of work on the winter plan.
So I think we're very concerned about the resilience of the system as we look from here. I mean, it is different in different places in the country, but even in our best performers, we are in a position where it only takes a small change in something, just a bit of a surge of need for whatever reason, and then some of our flow can really silt up. And what happens, as soon as one part of that flow silts up, then it becomes a problem all the way down the line. So one of the things that we've been focused on is what is it that we can do, things that we can control ourselves inside the NHS, because there's many other societal factors here, as we know, and sort of the relationship with social care, but what can we absolutely focus on in terms of the interventions that we know work, and using our GIRFT and our ESIS teams to support those organisations where we're most worried about safety and experience, which is what we have been doing. We also have been doing additional work in terms of our operational response. So when we do get into those situations where waits are unacceptably long, how do we safely make choices to balance risk across the system? I know this is a discussion every winter, but I think we are concerned. And one of the things that we don't have this winter that we did have in the previous winter is some of that additional capacity. We're really reliant on our process improvements and our interventions this year, which, as I say, there's been fantastic progress on, but we don't have that ability to surge our beds much higher than they already are, We don't have additional money to support social care discharge like we've had in previous years. So I think, it's we're doing everything we can to prepare, but I think it will be challenging in particular places at particular times.
Andrew, and then Andrew, then Jane, and then so Jane, if you we'll gather those questions up, and then if you pick them up as either a batch or as a couple, that'd be great. Andrew.
So if I recall correctly, last year was the first year since 2015 where performance against the constitutional standards did not deteriorate, which was really good news. So big emphasis this year clearly on betterment to try and get patients through as quickly as possible. Just to get your reflections would be good, Sarah Jane, on 12 hours, because that for me is the real acid test around flow. And to what extent do you think we can further improve our performance against that particular standard? And the other one is on mental health, where I thought every acute hospital had got a liaison service in place that's 7 days a week. Is that still correct?
Can you hold those, and we'll just pick up any comments to Jane? Do you want to come in?
Two slightly different comments or questions. One, just sort of thinking ahead, particularly to winter, the report mentions good uptake in of pharmacy first, but just interested to know, and it says it's sort of continuing to pick up, just wondering how fast that pickup is going, whether there's a plan to accelerate it, whether that would make a helpful marginal difference in different systems. So just wanted to understand a little bit more about that. And then the other point is sort of a bit sort of into the detail of the report around longer term conditions and prevention. Mm-hmm. There's an interesting piece around the pilots on blood pressure check services in wider primary care settings. And it says that's going to run till summer next year and then be evaluated and report by the end of August. I suppose I'm just interested, particularly thinking to a link to the health and work agenda, how that will be evaluated and then how quickly that could be stepped up if that evaluation is sort of seen to be successful.
Do you want to have a go at those? Then I'll bring in. I know Robert wants to come in.
If it's okay to ask Amanda to pick up the ones from Jane, if that's okay, Amanda Doyle. Amanda, if that on the 12 hours, I mean that I think is the most important of the metrics to focus on from a safety perspective, and we haven't made as many inroads into the 12 hours as we have in the 4 hours and the Cat 2 response times. It is the focus of our activities when we're working with systems from an NHS England perspective. So the ones that we have selected to give additional support to in the run-up to winter, it's been really around the 12 hours and the overcrowding in the department. And as you know well, Andrew, that is really linked to what is going on in the broader hospital and our abilities to be able to move patients through the system. I think one of the things that we've noticed in quite a lot of the trusts that we've worked with, although there are clearly issues with discharging patients out into community and social care services, there are things between the emergency department, the acute physicians and the specialties that we can do. So we will continue to focus and keep going with it. But I agree, it's it is the metric and we need to be very, very focused. In terms of liaison psychiatry, yes, that is in place across hospitals, and we've all the work that we've done between the mental health and the emergency department teams are saying that patients are having those assessments and plans put in place in a timely way. And the majority of time that's working. The issue becomes when it's really clear to that liaison psychiatry team that patient is going to need an inpatient mental health bed. And whilst we can initiate some treatments in an emergency department or an acute hospital environment, it's very difficult to really start the therapeutic pathways. So those services are working, and again we've got learning between the everywhere to check we're all doing it in the best way. But we still need to get patients to the right place, and we just can't always do that.
I mean, Adrian and Mark, you might, when we come to that paper, pick up on that if you want to add to that point at all. And then was
Amanda touch on the pharmacy first and the...
So, as you know, we had really enthusiastic adoption of pharmacy first delivery from pharmacies across the country. very, very high proportions of pharmacies. It was planned to have a gradually increasing trajectory of numbers, partly because pharmacies need to establish the systems, but also it relies very much on a change in patient and GP behaviour, and so we had to embed that. That continues to grow. A lot of the conditions that are covered by the Common Conditions Services are more seasonal conditions, so minor infections, and so we're expecting another growth over winter and have accommodated that so that patients starting to get sore throats, coughs, etc. can access pharmacy. And we are evaluating it, so early, teething troubles around IT, for example, are being resolved as we go along. And the evaluation around things like use of antibiotics for purposes of avoiding antimicrobial resistance are ongoing. As far as blood pressure checking in wider primary care settings, we already have a very well established, very strongly performing programme of blood pressure checks in pharmacies, and what this pilot is doing is looking at widening that out to people like dentists. It's only just started, but the plan is to evaluate that. Any opportunity to check blood pressure and identify untreated hypertension is a really good prevention opportunity.
Thank you, Amanda. Robert, I think you had a comment or question.
Yeah. So the improvement in cancer early diagnosis is encouraging. I mean, it's not where it needs to be yet, but it's certainly an encouraging trend. And rapid access to diagnostics is key to pursuing that positive trend. Community diagnostic centres, I'm sure, are part of that. My question is this. So I think direct referral by GPs for diagnostics is something I'm very much in favour of, but one of the anxieties about it is that it's amplifying demand. Demand is going up. Can you comment on whether direct referral is part of the increase in demand, or is it just the increase in demand because there's an increase in demand?
I think we're seeing increase in demand from all modalities, and I think that's why we need to just explore a little bit and understand a bit more what is going on, because it might be that this is entirely appropriate and that getting that fast access to the, that is preventing from patients from pursuing other parts of pathways. But yeah, I think we need to come back together and explore this in more detail.
Should I just make a comment to that? In the past, where single diagnostics have been rolled out to GPs where they previously weren't available in lots of different places over years, evaluations have shown that it doesn't increase the number of inappropriate investigations. Yeah. Often GPs were referring to acute trusts simply to gain access to a diagnostic.
Yep.
Thank you. If there are no other comments, Sarah Jane, thank you very much. Julian, can we hand to you for the latest financial position?
Sure. So, at the risk of sounding like a broken record, I've said the reality is that this year will feel much tougher than most. There's no doubt the finances are going to be challenging, and we're asking a lot from systems, ICBs and providers. They need to deliver an unprecedented circa £9 billion of annual efficiencies, which on one measure is about sort of 7% of their total allocations. So that is a big ask. Although it's tough, I don't think it is impossible. And look, it is a testament to the hard work that people are putting in, managers, staff, across the board, that this year they've already made, to the end of month 4, £2 billion worth of efficiency savings, and that is 300 million more than at the same point last year. And when you look at acute sector productivity year on year, to the end of month 4, we are about 2.8 percentage points up on 23-24, and you can see sort of steady growth over the course of the first few months. So a lot of good work going on. You look at agency spending as a percentage of total pay costs, it's the lowest it's ever been, well, certainly since about 2017, which is the earliest we have data for. And the NHS is on track to reduce the gross spend on agency by £500 million by the end of this year. So real work going on, real savings being made. And that is against a backdrop where, as Sarah Jane has just explained, we are making progress on performance, though it is tough. And, no one is claiming we're where we want to be, but we are holding things together and making progress in almost every area, including, falling waiting times. Now, as the paper says, despite that, the aggregate system position shows we are above plan. At the end of month 4, for the NHS, at the kind of NHS England mandate level, we are £387 million above plan, but within systems themselves, they're £487 million above plan, and that is in part driven by industrial action, where, using similar estimates to the ones we used last year, that accounts for about £180 million of that 487. And we are ahead of where, we were this time last year when things looked equally, were equally tough. And we have secured extra funding to cover those industrial action costs, which we have or are in the process of giving to systems, along with the funding to cover the pay deals that have been agreed by the government and with unions. So it is hard. We're behind plan. Really important to say that, as I said at the beginning of the year, we really do not have any sort of real contingency, and even to get to the point we have got to, this is not free money. We have had to limit spending on other programs and other pieces of work on transformation and capacity building. So, this is categorically not what we want to be doing now, particularly when you think how we need to fix things within the NHS and deal with the issues that have been raised in Lord Darcy's investigation. Now, in order to deal with this issue, as I have described in the previous board, we have strengthened our oversight and intervention regime for the most challenged systems. And I've met with a lot of them. We have gone through where they are on recovery plans. We can see where they are on it. We can see where they are still struggling to get on it. We are agreeing what actions they need to take to get back to the plans that boards themselves agreed. And actually, I think it's just important to labour that point. This is things boards agreed and signed off within providers, within integrated care boards, and within sort of the integrated care system. We've been clear that there's no further wiggle room. So whilst really good progress has been made, there is a lot to do, and there's a lot to do as we head into the winter, whilst we also are dealing with with winter and performance, and people need to work out how they're going to do both. But that is what the vast majority are doing, and you can see that basically half of providers are on plan as we speak today, with all of the challenges that everyone is facing. We know it's tough, but it is the reality of the economic situation we're in, and I think it's just never been more important for systems and providers to deliver the plans that they agreed. So progress, lots to do, and we will work with people, support people to do what is necessary. But in the end, it isn't just the finance director; it's the executive team owning what they've signed up to and working out a way of making it work.
Thank you, Julian. Wallen, you want to come in?
Just very briefly, Julian, you mentioned the overspend was around £500 million, 487 million. But if you actually look at the numbers, the expenditure was closer to £1 billion. And some of that came back through higher revenue. Can you just sort of unpack that a little bit for us?
Yes. So, I mean, there are always variances between expenditure and income, and some of this will be, even as people get, it always depends on how they've profiled income, including from like research, commercial activities. But in part, some of this is also where people are really delivering well on elective activity. I mean, compared to the average from last year, it looks like on a sort of evaluated basis, people are doing 5 to 6% more than they did last year. And that is actually why we are seeing progress on the waiting list. Is why when, at the end of July, year on year, the waiting list is lower. It's why I think we will see that continue. And indeed, let's hope the sort of gap between last year and this year, sort of opens up. But that is why. So some of this is people are doing better than their initial plans in getting through elective work, and that is in part also reflected in the sort of improvement in productivity.
Thank you.
And
Richard, so this feels really fragile, Julian, particularly in a number of settings that I know are experiencing real difficulties in hitting the plan. To what extent are we supporting those systems? I mean, I would urge all the boards concerned that, they really, really focus on the money. There's also, the issue of delivery against 4 hours and the electives. It's a really challenging agenda. But ultimately, if we haven't got the cash, we can't do a hell of a lot. So we're reliant on boards to deliver the plans that they set off and agreed to at the beginning of this year. And it's their responsibility to do their bit, unless there are, significant mitigating factors. And it'd be just helpful just to give a flavour of some of the support we are giving those organisations that are really struggling.
And I know you've seen some of this in some of the RSPs that you chair and so on. Yeah.
And I think, Richard, some boards got off the mark. They may have a really challenging agenda, but they've got off the mark at the beginning of the financial year and done so with a great deal of discipline. I think in other settings that discipline hasn't manifested itself in the results that they signed or the plans that they signed up to. So there's a real challenge now. We're halfway through the year. Yeah. And some providers have got really, really demanding targets to deliver by the year end. So it's pretty gritty stuff.
But it's taken obvious, if you have to get a saving in 12 months and you've only then got 6 months left to get the saving, you've got to get twice the rate. So it's very difficult.
It is really gritty stuff. We have identified. We are working with, I should know the precise number off the top of my head, but like 10 to 12 systems where we have budgeted up a very, senior NHS finance person with some consultancy support that we have asked them to source to really look at their plans, actually look at the way, have they really got the mechanisms in place to deliver their plans and what further opportunities might they have. I will say one of the things that they are consistently identifying in those places which are further off plan is actually that the kind of basic controls, although sometimes in paper they're in place, they're not working effectively enough. So in part, it is actually working with them, actually just to get some of the basic controls, decision making about jobs and vacancies, and the approval of business cases and things of that ilk, just to make sure when the money is this tight, the basic disciplines are really working well. Jackie and Andrew New from supply chain, we are trying to identify where they can support to go into providers and trusts, literally to look at the commercial spend and identify where we know we can buy things through supply chain at a better price. We're doing the work on energy contracts, so we're trying to find in the commercial space. We are working up, actually through some of the improvement work, programs to identify like what best practice looks like, frankly, on rostering and deployment of staff, and to try and source like expertise to gather people together, because some of this is we've also had quite a turnover of general management, and how do we sort of give people some of the, just support across the NHS to sort of give people some of the basic skills that they need. So that sort of gives you a flavour of like the short-term specifics where we can honestly go in and sort of identify new opportunities, as well as how do we support some of the improvement work, which is actually what is going to be necessary to make sustained and sustainable change.
And failure to deliver this year causes a problem for next year for these organisations as well.
And my encouragement to boards is you really have to look now at the kind of workforce as you go through September, October, November, because that is actually where the growth last year was much larger than people had planned for. And I think this is the moment where it's great, recruit substantive staff, that is the way we want it, but you have got to take out the temporary workforce costs that were otherwise plugging the gaps, and that requires some management discipline.
Thank you. Any other, Jane?
Just a couple of points if I can. The DARS-I report, which I agree, very, very clear, very good report, was also extremely clear about the need to not raid capital, to keep capital budgets, to maintain them and to invest them wisely. And obviously, as a board, we've expressed particularly strong interest around investing in long-term tech and IT. Just wondered if you could expand a bit on where that sort of conversation is at, because obviously lost a bit of time in terms of the kind of capital plans that were being discussed around the time of the pre-election budget. So just wondered if there's anything that can be said on that, picking up DARS-I's emphasis on it. And the second is just around elective. I mean, Amanda mentioned the further, faster groups. I think it was obviously a lot of emphasis on that announcement recently. I just wonder, as they get going and sort of, are evaluated, will there be any attempt to feed in the learnings from that process into the wider elective piece to kind of, if you like, give that more focus and direction? Because obviously at the moment we've got this slight conundrum that there's lots of fantastic activity going on, colleagues in the NHS are doing all this great work, but it's also creating a pressure. So I just wondered whether there's any opportunity for that to become more focused over time.
Do you want to go with the first one, Julian, on the capital?
Well, look, clearly we continue to try and prioritise capital investment. Last year with the department and the government, there was the need that where there were programmes that were underspending, as opposed to decisions to stop things, there was a requirement to move capital to revenue in order. I mean, basically to keep the sort of show on the road, the operation on the road, and sometimes you face these, I mean, it isn't actually our call on that, but the sort of almost necessary decision as to how do you deal with the day today, and no one wants to move capital to revenue, but if you really have no choice, how do you keep serving patients today where that is an absolute necessity? So I think it's clear that is not where people want to end up, but under like a force majeure circumstance that can become necessary. I mean, let's see how we go through this year.
And I would just add, I think I referenced in my opening sort of remarks about some key elements we've been working on. We at the NHS England board, so the NHS England team have been working on, and that included the long-term infrastructure strategy, and I would hope very much it's clear that they would feature as part of the 10-year health plan. And so let's see. Do you want to pick up on the point about the lesson, how we take lessons learned from the initiative in the 20 areas of deprivation where we're seeing people out of work with ill health and concentrating effort there?
Yeah, no, I mean, absolutely. So I think just worth saying that Tim Briggs, who leads the GIRF programme, has been an absolutely core member of the elective team within NHS England for some considerable period of time. So he works really closely with Jim Mackey, who is the SRO for that programme, and has run a series of further faster, I think 3 now, cohorts of that programme have run. So in a sense, it's the other way around, that actually what's happened is what he has been able to do with colleagues is learn from what has happened up till now to be able to then shape a programme that will focus, as you say, on the sort of further faster 20. So I think that has been a real learning experience over the last few years about really understanding what that combination, as I said earlier, of the clinically led, data-driven, improvement-oriented intervention can help organisations on the ground, as it were, actually do very practically to improve their productivity, their efficiency, their outcomes, their quality, their patient experience. So things that really matter to patients and to staff, as well as some of those headline outcomes. So I think we really welcome now that renewed focus, if you like, on using improvement as a key tool to drive both efficiency and quality. So with Sarah Jane, with Emily, with others, there's a lot of work going on under that NHS Impact umbrella at the moment to make sure that we really are using the best of all the bits that we've got at the moment at scale as we think about the sort of challenge of delivery going forward.
Thank you. Vin?
Yeah, 2 quick points, Chair, thank you. So the first thing is, in addition to the things we've mentioned, I think under the programme we've made a big investment in data and improving our data flow. So there are new data compartments on the model health system that will enable trusts and ICBs to compare themselves and benchmark themselves. In the private board earlier today, we saw a great example of how the federated data platform can be used both to improve productivity, make best use of the staffing that you have got. And then just reflecting on my previous background as a medical director, and I think all of us here have been on boards, I just want to re-emphasise with Julian, this is not just a finance responsibility. When you work in a really effective executive team, the medical director, the nurse director and others take as much responsibility, not just for delivering the plan, but also making sure that quality is maintained as well.
Vin, thank you. Steve, last point on this.
I think that's a really important point, and over the last few months I've done my currently twice yearly meetings with all the medical directors around the country, and we have at almost all of those had a discussion around productivity. We brought the productivity team, and the point that I've consistently made is that particularly now, of course always, but particularly now, it's the job of medical, nursing directors, other clinical leaders to support their financial colleagues to ensure that balance between ensuring that quality is maintained but also recognising the financial challenge that we have is the right balance. And actually, when I meet finance directors, it's the same message the other way around, that this is the time that finance directors, more than any time, have to have that, that quality thing on their shoulder tapping and saying, have we paid attention to this? So this is not about one group or another. This is around, both groups, and of course, really good boards, whether it's ICBs or provider trusts, have always and will continue to get that balance right and have it at the forefront of their minds.
Thank you. I'm going to move us on, if that's right. We've got 2 substantive items still to cover. The first, actually, Amanda, it's you, I think, and then with Kevin Lavery and Andy Knox, but on integrated health and care. Do you want to introduce it, Amanda?
Thank you. So the strategy for the NHS over recent years, from the long-term plan and then built upon by the fuller stock take, and now more recently emphasised in the Darcy review, is about boosting care out of hospital for patients, focusing on better care for long-term conditions, and improving the way in which services are integrated so that care is more seamless for patients and therefore outcomes are improved. We've now also got commitment from the government to 3 strategic shifts for the NHS, which are hospital to primary care and community services, analogue to digital, and from treatment to prevention. And all of this approach combined to be manifested almost through the development of neighbourhood health services, where people can be optimally treated closer to home, where they can get as much of their care as is possible without being admitted to hospital, and where there's a real focus on not only prevention of development of disease, but prevention of exacerbation of disease and frailty, so that avoidable treatments and hospital admissions can be put in place. This is particularly important in populations with the greatest health inequalities and the greatest health challenges, resulting in the poorest outcomes. And so I think there's a real opportunity, while we're sat here in possibly the place with the greatest health challenge in the country, to listen to some of our local leaders about the things they are doing to help improve the health of their population through looking at how they integrate services. And so we've got Kevin Lavery, Chief Exec of the ICB in Lancashire and South Cumbria, and Andy Knox, who is an Associate Medical Director, but also has been a GP in Lancashire for quite a long time now.
12 years now, 14 years in Manchester before.
So I'll stop talking. I'll hand over to Kevin and Andy.
Great. Well, colleagues, welcome to Blackpool. It's really great to have you with us. Not just famous for when Strictly comes to town also, but if you've not taken the opportunity to ride the big one, you need to do so before you go. It's without a doubt my favourite roller coaster. So, listen, Blackpool, as Amanda has so kindly she knows this town so well. She has served this town so incredibly, and the whole of Lancashire and South Cumbria for a long time. And Amanda, thank you. There are some really important things to take hold of Blackpool as you spend some time here. And we're excited to show you some of the great work that's going on across Blackpool tomorrow. This town has the lowest life expectancy of any town in England. It has the lowest healthy life expectancy of any town in England. Men here are in their early 50s, 53, before they're getting significant ill health problems, and women only 54. That is significantly worse than other parts of England. People hit significant frailty in their early 50s here, with high burden of chronic disease across the town. 20% of the population here smoke, 22% of the adult population say they are depressed, 18% compared to 13% nationally have hypertension, 9% have diabetes, 75% of our adult population is overweight. That's 82,000 adults in the town. And then when you think about what the impact is on children, we have 3 times the national average number of children in care in Blackpool. We have the lowest educational attainment of any children in the country, and very, very high population of under 5. So you can, what I just wanted to say, there's a stark picture here, right? And yet it's a wonderful town, full of huge potential and actually amazing things happening at the same time. We've got a really high number of asylum seekers in the town. One of the groups tomorrow will see the work of FCMS here, but you won't be going to the asylum seeker work, but if you took a stroll down to the Metropole Hotel, you'll see hundreds and hundreds of asylum seekers all crammed into a hotel together, where actually currently we have 18 pregnant women and a host of unbelievable complex tropical disease and significant mental trauma. So there's complexity to deal with here. And although we've got very, very high levels of poverty, in fact, in some wards, 70 to 80% of the population live in the poorest 20% of the population in terms of index of multiple deprivation. And when you look at the housing in Blackpool, I think when you walk the streets, some of it could potentially shock you. 75% of our private rented sector housing is damp and or mouldy, which has a massive impact on respiratory disease in the town as well, with low earnings and only 66.5% of our residents being economically active compared to 78% nationally. So some big challenges for us. And the truth is that actually our model of care, therefore, is unsustainable. If you multiply that across Lancashire and South Cumbria, Blackpool is unique, but actually not far behind it are places like East Lancashire, Hyndburn, Burnley, Blackburn, Barrow-in-Furness. We've got some big things to contend with together. And if we carry on as we are, by 2038, we're going to need 60% more hospital beds than we've got now. And there's going to be a 15% rise in long-term conditions and chronic ill health. That is financially an impossible conundrum. So we know there's got to be a radical major shift, and we really welcome the Darcy report as a result of many of the things that he's saying. So we're trying to take an approach here in Lancashire and South Cumbria to improve the health of our population through the tackling of health inequity. And so here are some of the things that we're on with in terms of obviously integrating care as much as we possibly can and shifting towards prevention, really seeing the power and potential of primary care in partnership with our public health colleagues and our community voluntary faith sector. So over the last couple of years, we've taken 48 clinical leaders in primary care through a Population Health Leadership Academy, and we now have 48 health inequity clinical leaders in each one of our PCNs. I was with many of them this afternoon across Blackpool, looking at the incredible work that they're doing around detecting and protecting people from the effects of hypertension. Last year, we took 48 senior leaders through our trusts, and this year we've got another 48 leaders from primary and secondary care going through that programme, and 18 members of our exec teams and board teams, which is fantastic, because it's beginning to change our focus and our lenses towards a health equity approach, which makes a big difference when you actually look at the data of the people who's flowing into our trusts and where our big cost lies. It actually comes from our communities who struggle most with their health. So we need to give better focus and better integration into those neighbourhoods and those communities. And you're going to see some of this in action tomorrow, which is going to be really exciting for us to show you. And you're going to see the power that primary care really has when it works in an integrated way with partners in a community to really affect change. So in the last year, for example, we've here in Blackpool, we've detected 2,000 new people in terms of undetected hypertension and treated 5,000 new people to target. Over the whole of Lancashire and South Cumbria, we've gone from 59% of people treated to target to 72% just in 1 year. We've seen a 50% reduction in our CAMS waiting lists in places like Fleetwood through innovative working with communities in a radically different way. We've seen a 50% decrease in ED attendances in East Lancashire for our frail elderly through the Enhancing Better Care programme and taking an improvement approach. And we've seen a much, much greater improvement in terms of early cancer screening and diagnosis in our most disadvantaged communities. And this year, we're focusing particularly going into the winter on our mental health crisis and our respiratory crisis that we have in these communities. And later this month, we will launch our system-wide improvement hub in conjunction with the wonderful David Fillingham and Ailsa Brotherton, as we try and recognise that it is only through a system approach and a left shift towards improving the health of our population through the tackling of health inequity that we're going to deal with some of the major problems that we're facing. But innovation is alive here, enthusiasm and gusto is alive here, and we're beginning to work in some really good new ways in our communities.
Thanks, Andy, and thanks for the invitation to attend this board. I think what Andy's been describing is a predicament, isn't it? It reminds me of Charles Dickens' A Tale of Two Cities. It was the best of times, it was the worst of times. Blackpool's got some of the really most difficult health challenges, but at the same time, there are some brilliant opportunities here and some great innovations. And I guess the $64,000 question is, what do we do about that? Understanding some of those challenges in Blackpool and the wider Lancashire and South Cumbria footprint, they're long-term and they are systemic. And many of them are system problems. Let me illustrate that with one example. If you look at the acute system, we've got 8 medium-sized hospitals, 8 elective care centres, 6 accident and emergency centres, 5 sets of support services, mostly on old technology and in some cases on no technology. We're spending, Julian was talking about agency staff earlier, £300 million a year on temporary staff at premium rates. We've got big pressures in urgent and emergency care. The cost of corridor care alone, 84 million. And with that, we know it's a relatively small number of people in deprived communities and frail elderly who are filling up accident emergency centres and being repeat customers. They're all problems, they're all challenges, but actually they're also all opportunities. So we have a vision and plan that is trying to look at those challenges and convert those challenges into opportunities. So it's that uplifting, positive theme. The recovery side of it is addressing exactly what Julian was covering earlier, all of the in-year issues, looking at vacancies, looking at costs, looking at discretionary spend. And then you've got the longer-term reform around transformation, very much aligned to Lord Darcy's report and the early announcements from the Secretary of State. There are three simple elements to that plan. Our back office. So we're now in the process of transferring close on 4,000 staff from 5 trusts into 1 trust to provide shared services, support services back to the system. We introduced a single collaborative bank for Lancashire and South Cumbria in December last year, which is starting to bring costs down. These are real examples of change. Acute reconfiguration, we've just had some external consultants working with our acute colleagues and our commissioners to effectively move to a networked acute system, which is based on quite a lot of detailed benchmarking around individual specialties to look at how they're sitting in terms of quality, patient safety, and value for money. Very strong correlation between the three, interestingly enough, but huge variations across our network. And what we're trying to do is get the best teams to work with the poorest performing teams within our system on that basis, rather than simply go for a big group structure, big is beautiful approach. And then finally, and most importantly, primary care and community care. Probably two big players here. One, and you've seen some of this, Richard, with your visit yesterday, about bringing long-term condition management out of acutes into community settings, but really getting on top of that UEC, that admissions avoidance area, using data to understand which people in deprived communities and in the acute elderly group are at most risk of being admitted, making sure that they're being seen by GPs, there are proper care plans in place, and there are appropriate services at the local level to make sure that we keep them at home. The big target there needs to be something of the order of 30% reduction over a period of time in that space, but that's the big opportunity. I think there are some areas where NHSE can help us do all of that faster, better, smarter, cheaper, and we will be meeting Julian to look at some of those in due course. But I'd like to leave you with one thought. We want to be famous as a system to be a place where problems go to get solved rather than a place where problems go to get really big. So thank you.
So thank you very much. I mean, I think really rather, you presented very clearly and cogently a extremely challenging picture, but also some of the steps forward and the avenues you're looking at that can help to mitigate and turn this around. But I'm just going to open up to comments and questions from colleagues. I can see a flood of hands going up. So I'm going to, we tend to do this, Kevin and Andy, by batching questions. Otherwise, it's a bit like watching Wimbledon or something. So we batch it up, and then you can choose which questions you answer, really. So we'll just work up. So Mark, let's go Mark, and then Mike. I think your hand was up, Mike. So we'll go Mark and Mike, Steve, Wal, and then we'll break for you to answer, and we'll work this way around.
And this may not be a question you can answer, but an observation. Kevin and Andy, thank you for that. And it's quite a sobering picture of what you face. Kev, there was one thing you said, which was you're trying to fix this in an integrated way where we are all completely bought into the vision of the 10-year plan and the observations of the Darcy report, but with no or little technology. And to actually address what you're trying to do is going to need a technological solution. And one of the things that's been bubbling around, Chair, recently is, although the 10-year plan is underway and it's going to take 18 months to develop, there are some things we are going to need, probably 4 things: a single patient record, interoperable systems, a single data architecture, an IT infrastructure that actually works at the point of care.
And those are going to take time to deliver in any scenario. And one of the questions, and this might be for Amanda and Julian, which is, I think those things are needed in any scenario. And if we wait till the 10-year plan is delivered in 12, 18 months' time, and then start to build the foundations, we may not even give you the technology you need for 5 years from now. And given the need in the system today, especially in this sort of really complex environment, it's like, are we really ordering this in the right way? As a reflection we should have as a board.
Yeah. Thank you. Thank you very much. So we'll keep going up. Mike?
Yeah, I wrote down sobering during the course of your presentation, so I will just repeat what Mark just said. And it's inspiring to hear you speak about the things you're doing to join things together. It would be great if you could share with us, not just with Julian, what if there are three things that we as a board could help facilitate. What would they be? Because then we can persuade Julian that he really wants to spend the money on it. So,
Steve?
A common question and a very specific question. So I think it was a very stark description, Andy, wasn't it, of the challenges you face? And I have been up to this part of the coast a few times. The first time I came up pre-pandemic was at the other end of the tram line from where we are now in Fleetwood. And I vividly remember walking through the streets, literally walking through the most deprived streets in Fleetwood, and meeting with the local community. And what really impressed me and struck me in that visit was the sense that the NHS was really going beyond just the delivery of health services into social cohesiveness, and really focusing on ensuring that it gave that support to keeping the community together, which is so important in the sort of circumstances you've described. And I just wondered whether, with all the challenges you have, and this is a sort of anchor institution question, whether you are being able to maintain that and go further forward. And then the second question was specific because you mentioned it on the Whitegate Centre that we visited, I visited this morning. Richard was there yesterday, which is a great centre. As you described it, it's in a sense, one of the polyclinics that Aradazi described back in the day. I was there a year ago, last October, and I was just kind of ruminating on the differences. So apart from Amanda's photo not being on the wall anymore, don't know what's happened to Amanda. I came up with a sense of sort of frustration that they felt that there was more that could be done in that hospital to community shift. And I just would be interested in your comments as to, with that great facility and with that model towards a community shift, what more do you think you could do, and how faster and harder do you think you could drive that?
So we're going to take one more set. I realise, and I've said you don't have to answer them all very specifically. You might be able to sort of theme them a bit. But Walt, do you want to?
I'd say if you can keep up with that, you're doing really well, actually. So two things. One, a bit like Steve. I'm sort of aware of the situation here. My brother happens to be a consultant at Blackpool Victoria, and visiting him and talking to him from my position and his position is sobering. But I wanted to sort of just focus on whether or not existing programs are helping or not, because some of the things you're talking about sort of fall into the Core 20+5 program, and I'm wondering if that's part of your solution, whether it's specifically designed to focus on the 20% most deprived populations, on the 5 key issues, and the intersectionality that comes with deprived communities and minorities and health inequalities. So just wondering if that's being a support for you.
Right, do you want to have a go at those? And I'm going to walk down this side of the table. But Kevin or Andy, how you want to deal with those?
Okay, I'll try and have a go at what things could help us do things.
And I'm going to be and we need to be sort of punchy.
Yeah.
Because there's going to be some punching coming down from this side of the table as well, isn't there?
So what could help us do things faster, better, smarter, cheaper, etc.? I think our challenge really is the analysis is good, the solutions are obvious. It's about making decisions and delivering at pace against that. That's the challenge. There are a few things. I think trying to get the recovery and intervention programs very much around a longer term perspective if we can, and creating a positive vibe around it so that it's seen as support, and actually this is a great leadership opportunity for us to do something quite special. I think that's one thing. It's a sort of psychology thing. I think there are decision making, both locally and with NHS around reconfiguration. We have a joint committee amongst our 5 providers. With your help, if we could delegate some of that decision making to that joint committee, and if you could fast track some of the clinical reconfiguration, that would really make a difference in our system. And then the third one is Better Care Fund. This could be a great opportunity to do some of that out of hospital. It's a sort of system, complicated decision making that really leads to compromise and suboptimal solutions. And I think if it was streamlined, you could do a lot more with that. It's 10 billion nationally plus. It's a big area, so a big opportunity. Andy.
Wow, good. Yeah. So, great questions. I mean, we agree with you on the technology. We've actually got phenomenal data capabilities across Lancashire and South Cumbria, but it's really difficult at the moment to actually be able to make those happen well across the system and join them up properly. So help with that would be great. In terms of your question, Steve, I think in terms of social cohesion, absolutely. I see really, really great work going on in our role as an anchor institution and as a convener of anchor institutions. So just up the coast from here in Morecambe Bay, we've developed an anchor collaborative where the NHS and the universities and our key colleges and BAE Systems and EDF Energy and all kinds have actually got together, and we've got a 6-point anchor shared network plan where we're not just wanting to tackle health inequity, and our private sector colleagues are really helping us with that, but they're also, we've got great workforce schemes now and great employment schemes and apprenticeship schemes and all kinds to really try and lift our own population out of poverty, but have long-term employability and improve the health and well-being of the population. So yes, we're seeing that, and it's expanding across the wider footprint. In terms of Whitegate and what more could be done, I had the privilege of going out to Valencia a few years ago as part of the Vanguard programme and seeing some of the work there. I would love to see just more integration of services, but out into communities. So rather than that separation where there's actually an us versus them still happening, and we're going to see this more with the kind of action potentially through primary care, we don't need to be in a situation with the complexities of what we're facing with people throwing stones at each other within our own camps. Actually bringing services out into communities and seeing a much better, stronger relationship between GPs and hospital consultants, providing those services right in the heart of the communities that need them. So, for example, in my own practice, we have a consultant elderly care physician who comes and runs regular clinics with our most elderly patients, and we have all of our most complex nursing home patients overseen and looked after by him. We have a similar thing with our pediatric consultant coming out into communities. So I think this is just the beginning of what's possible. Actually, what Amanda's demonstrating quite well is that we can have hospitals without beds, and when you combine that, it works really well. And then finally, in terms of Bola's work, she's a great friend. She launches our Population Health Leadership Academy every year, and Core 20+5 has been utterly transformational for the way we work.
Andy, thank you. I'm going to go quickly down. So, now, Julian, I think first.
So, I mean, look, in terms of joining up data, I would say that is where the federated data platform, like that is its purpose. So I'd say engage with us if you aren't all ready. That is the whole point. Secondly, actually my question, and it sort of builds on Steve's. So I think one of the issues is, how we get the right sort of planning for care at the ICB level, but at the kind of place level, be it Blackpool, what do you hold tight and what do you hold loose in order to help make the place work? And in your model, who is going to lead it at place? Because someone is going to have to lead it. And I think one of our hypotheses on this is you need a provider, who is both going to do the work and lead the work to pull all the other providers together. Look, is that how you are thinking about it? Because clearly this is at the heart of how we make this work across the country.
So I'm going to indicate to the people with questions, we've got about 5 minutes left because there's a very important next discussion which I want to create enough time for. So let's ask our questions as punctually as we can. So it goes Chris, Helen, Duncan, Robert. So
just two very quick questions. Andy, it'd be really helpful to know what more can the National Health Inequalities team do to help you? They sit in my area of responsibility, so useful to know that. And then secondly, as you know, I think we're doing some work on coastal health, and would just be quite interested to kind of know, actually, are there a set of issues that actually you can address more effectively by coming together with other people who fit into those kind of coastal health navigators?
And you may be able to answer both of those very good questions sort of with a yes and separately outside. They're very good questions. Helen?
The joy of being this far down the line is that half the questions have been asked already. So, first of all, thank you for a fab presentation. Great to see you again, and I really enjoyed hearing what was going on. Okay. Primary-secondary care interface is of huge interest to me, and I think in what you presented probably didn't do justice to the amount of amazing work that you are doing. And I sort of wanted the board to know there's a heck of a lot more going on than they have shared at this point. I guess for me, synthesising down what the financial levers to facilitate what you want to do, Andy, to pay for an elderly care physician to work in your general practice requires careful use of working around the fringes of the financial systems that we have in place, which my understanding is in general are obstructive to that sort of creative approach, not facilitative. And I think it would be really helpful. They might be far too big for you to answer here, but I'd love to know that somebody's picking up on this and looking creatively now, not just something we can do in big new contracts in the distant future.
Duncan, quick.
Yep, so 3 points. One is, actually, I was up here last year and visiting Queen Victoria Hospital, and the thing I was really struck by then, and listening to you now, is the complexity and additional safeguarding support that is required. So a visit to A&E is not just a visit to A&E. It is being really mindful about that. The second thing is, I'd be really interested in hearing more outside of here around the population health programs and leadership programs, because there may be some things to learn for how we prepare our leaders across the NHS in relation to that. And then my third point, I'd be really interested to hear about, are there lessons in the way that you work with the voluntary sector locally, given all the support that's required, that we could share with other parts of the NHS?
And on that very good set of 3 questions, I would just say we've also got dinner tonight, actually, where you're both guests, and actually we can broaden this conversation with the board and other community and local authority leaders and so on. Robert?
Yeah, well, so I mean, it's just fantastic to hear both of you speak, and I think you're people here are very lucky to have leaders like you with the energy and enthusiasm when faced with such challenges. 2 very quick questions. One is, in terms of inequalities, and there's nowhere better than here, I would say, to answer this question or think about it. Have you come up with surrogate markers of addressing the inequalities? Because addressing them is going to take years, but have you got some surrogate markers that others could borrow? And the second, you've already said something about primary, secondary care. In COPD, which is mentioned specifically as a particular issue, I know about an integrated respiratory service at South East London where they've got a sort of hospital, a virtual ward round. I don't know whether you're doing something like that in relation to COPD.
Thank you, Robert. So in about 4 to 5 minutes max, it can't be more, but this is a really important conversation we need to have on another topic. So can you hit as many of those as possible? Yeah. And otherwise, put them to dinner tonight, actually.
I think in terms of inequalities, probably the biggest single thing we can do is that programme around admission avoidance. We know that it's deprived communities in particular that are generating. So that really, really makes a big, big difference. So that's a big, powerful play. There are some really good prevention programmes that Andy has mentioned too, which he may wish to add. I'm going to do the politician's answer and say we haven't mentioned much about mental health. but we've got a fast improving trust here that's making a real difference. It's a real success story. And we've done one significant transaction that's been talked about for years of basically moving the CAM service from East Lancs Hospital into the Mental Health Trust, and we're going to do the same in Blackpool. And these were done at pace, and that's the sort of thing we need to do more of going forward.
Yeah, great. So super quick, as 2-3 word answers. What more can the Health Inequalities team do? They're amazing. We've got a great relationship with them. I don't feel like we're lacking anything in our relationship. In terms of coastal health, I'm down in Parliament giving evidence on this next week, and I'd really welcome the opportunity to create a coastal health network. There are challenges in coastal communities that you don't find anywhere else, and we need to highlight that and change the conversation. Financial levers, actually, you know what? A lot of it's about relationship. When you've trained together and you work in the same patch and you care about the same people, you find that people in hospitals want to come out and work with you differently. So it doesn't necessarily need finance, it just needs friendship. I think there's something about you're absolutely right in terms of the safeguarding and trip to ED here in Blackpool. We could talk about that over dinner. But in terms of the population health leadership programs, I do think we've created something really beautiful and special here. I was teaching on the Global Health Leadership Program in Oxford a couple of weeks ago, and health ministers from right across South America were there, and they've asked if they can adopt our population health leadership program across all of South America, which is pretty exciting. Our relationship with the CVFSC, we can unpack that again over dinner, but it takes time and lots of coffee drinking and really listening to uncomfortable truths of what's going on in our communities and brokering different kinds of relationships. Surrogate markers, I think if you study particularly the work in priority wards, you can make incredible differences quite quickly, and it doesn't have to take a long time, some of this. It's about focused care in the right way and making sure you work with communities differently. And in terms of COPD, the answer to your question is yes, we've got some great programmes going on.
So can I, in the place of Strictly Come Dancing in Blackpool, thank you for the quick step. That was very good. And slightly laboured conversation, but thank you very much. And as you all enjoyed my joke, we're wasting time, actually. So, Kevin and Andy, thank you very much for that. So let's go on to the last item, actually. Delighted, actually, we've got Adrian James and Mark Ewan. So Adrian, National Medical Director for Mental Health and Neurodiversity, and Mark, our Head of Mental Health. So welcome. And over to you, really, on the topic. It's supporting strategy and actions taken to improve quality and community services for mental health is the title. And you provide us with a very good paper, but you want to draw out the main points, and then you've seen the way it works, and I'll attempt to keep it under some form of control.
Well, thank you, Chair. I'm very pleased to be here addressing the board about this important issue. I will assume that the paper has been read, but I'll summarise the main points and the actions that we're taking. So what's the patient group that we're looking at here? They are those with serious mental illness, so that's mostly those who are experiencing psychosis, mostly of those would be schizophrenia, bipolar disorder, or some with emotionally unstable personality disorder. There are approximately a million people who experience those conditions, and a lot of them would experience hallucinations, delusions, and paranoia, and be really very unwell with their condition, and it will affect all aspects of their life, their education, work, and family life. So what do they need from the NHS? They need an early diagnosis, they need early intervention. The earlier we intervene, the better the outcomes that they have. They need conventional community treatment in partnership with primary care colleagues, and most will be managed in those community teams without further specialist input. But some will get into crisis. They will need alternative to admission so that they can get support at home. Mental health services have been running wards in the community for decades in terms of the intensive support we give people at home, but also we need inpatient care as well. For those who find it difficult to recover, we have rehabilitation services. For those who have been in contact with the criminal justice system, forensic services who also operate in the community. And we also have assertive outreach services, and I'll come back to those because there has been a particular focus on those in the last few months. So what are we doing to improve quality? There were a number of plans with the long-term plan, £1 billion extra invested into community mental health care, and as a result of that we have 71% of those experiencing a first episode of psychosis being seen within 2 weeks. That's really a pretty stunning statistic. We have a programme at the moment around the culture of care within mental health services. Every single trust in the country is signed up to this and are engaged. We have a number of quality improvement programmes that have been very successful, for example, in reducing restrictive practices and improving sexual safety. And we're currently piloting, just launched this, 6 new pilots looking at models of care that are different to the ones that we provide at the moment on a neighbourhood basis, population around 50,000 individuals, taking the best learning from all over the world with open access, partnership with local community groups and the voluntary sector, co-production being central to everything that's done, and building up trusting relationships that are lasting, so there's continuity of care. But we also recently we've got the review of the Mental Health Act and legislation that will be introduced into Parliament, and again a lot of that is about improving mental health care, improving the experience that our service users have, and particularly addressing inequalities that have already been mentioned in this meeting. So we have a number of challenges: increased demand, increased referrals, long waits in emergency departments have already been mentioned. We have high numbers of out-of-area placements for those who just require conventional inpatient psychiatric care. We have high occupancy rates of above 95% and staffing challenges. But with all those challenges, we now have 1 million more people who are being seen by specialist mental health services year on year than were seen before the pandemic. And again, that's a tribute really to our staff who have redoubled their efforts really to provide that care. And we have had a number of serious untoward incidents that have occurred that have caused understandable extreme concern from the public and those working in services and those who use services. And one of the ones that was particularly shocking and tragic were the death of 3 individuals in Nottingham. And of course our thoughts must be with friends and family of those who tragically died. One can't imagine the impact that it's had on their lives and everything that they do. And we owe it to them to do all we can to minimise the chance of these tragic incidents happening again. So that particular group that we're looking at, they are those that require intensive community treatment. So the profile of those individuals, they would normally have a psychotic mental illness. As part of that, I've already mentioned delusions and hallucinations, and these appear as reality. So I'm talking to you, you're hearing what I'm saying, you see me in the room, and if somebody said to you later on, I wasn't here, I wasn't saying those things, you'd find that hard to believe. And if somebody was saying that was what was happening, then you would probably question them and you might not be inclined to engage with them. So this is a very challenging situation for patients and for staff. And again, I want to pay tribute to patients and staff who work very hard to build those relationships and build up those the trusting relationship. But unfortunately, this can lead to some patients disengaging from services, not coming to appointments, not taking their medication. And we know in those patients who experience psychosis, this can be highly risky for them and sometimes risky for other people as well. So what's been happening as a result of these concerns? There are very specific actions in relation to Nottingham. The Nottingham Trust are in the highest level of scrutiny. There's been a local investigation. The CQC reported those actions have all been looked at both locally and nationally, and we're expecting the independent homicide inquiry report to report in the next few months. But we didn't want to just look at one area because we wanted to make sure that we looked at all parts of the country to see what the challenges were. So on the 26th of July, we asked all ICBs, all 42 ICBs, to look at their approach to assertive community treatment for this patient group. What were their policies? Could they identify these individuals? Could they actually monitor those individuals? What are the gaps in services? What are the challenges? And what next steps are they taking, and would they like to take? And we wanted them to report by the 30th of September. We also issued a renewed guidance around assertive outreach treatment. So this is about policies. One of the particular concerns we discovered was that there was a policy in Nottingham where if somebody didn't appear to an appointment on a couple of occasions, they were discharged from the service. That may be appropriate for some patient groups, but for this patient group, it causes a huge amount of risk and is clearly not right. But also issued new guidance around use of medication, particularly depot medication, and use of legal frameworks, obviously particularly the Mental Health Act. The initial feedback that we had was about a third of trusts had assertive outreach teams dedicated to this approach. A third had a particular approach, maybe dealt with by a different team, and a third didn't have a very specific approach for those individuals. We've now had the responses from all ICBs. I'm delighted to say 42 out of 42. We need to analyse the feedback that we've had, and we have seen some very good practice that's going on, highly effective assertive outreach teams providing excellent care, reducing risk for patients and for the general public. But we've also had highlighted significant challenges, a lack of a specific team, workforce challenges, challenges with data. And they've also requested as part of that more central guidance, more central training, sharing good practice that is out there, and a real look at all parts of the system, all the requirements that people with severe mental illness have in order to provide the best care. So we don't just look at one part of the system and shift the risk from one area to another. So the ICBs have been asked to report through their public boards. That will be being done within the next few months about what the situation is locally and what their plans are. Regional teams are also reviewing the ICB returns, and they'll be reviewing those by the 14th of October. Centrally, we'll be following up the concerns, actions, and what we're doing in 6 and 12 months, and obviously briefing the executive team about that. We are also reviewing the learning that comes from serious untoward incident investigations, particularly homicide reports, and Aidan Fowler is leading a piece of work on that. I'll be sitting on the group, so to make sure that we both learn lessons, but actually that we respond to them for the clinical care of patients. And finally, we're going to be undertaking a longer-term review of all parts of the system so that we make sure we have a joined-up approach to everything that's happening. And we heard earlier on about the emergency departments. We have more longer waits for those with severe mental illness than any other group. That has a knock-on effect to the rest of the system, as well as not providing optimal care. And I think, Mark, you were just going to say something about the urgent and emergency response, but it's very important that we get all parts of the system working in harmony. There's really great practice that's going on. I visited the South West Ambulance Service just a couple of months ago, and they've got fabulous systems working very closely with the police, with local mental health services across primary care. And I think there's a real opportunity here. There is good practice. There's real willingness across the whole of medicine to address this and make a real difference and reduce significantly the chance of these tragic events happening again.
So, Adrian, thank you very much. I'm going to go around. You've seen how it works. So we're going to go this way around this time.
Mark, do you want to just say?
Mark, sorry, do you want to?
Well, I'm happy just to answer. I know some of the early questions about the what we're doing in mental health to support the resilience this winter, and I just wanted to say there's 3 things that we're putting in place ahead of this winter that were not in place last year. One of them is the establishment of 111 option, mental health option, that was not in place last year. That is going to be a game changer in terms of enabling patients to access the alternative crisis infrastructure that we've developed for mental health through the long-term plan. The second is the rollout of mental health response vehicles. They were not being rolled out until February this year. We've now had about 58 being made available to systems. Some of the evaluations that we've seen on similar vehicles have had conveyance rates to ED at 19% compared to their comparisons of 54% for those that didn't have mental health available at the scene. And thirdly is establishing OPAL for mental health. That's going to bring daily and weekly information on the pressures that are facing not just in ED, but also the waits that we're seeing for beds in the community and in things like OPES. That will make it much easier to actually manage the pressures we're seeing.
Thank you. Very good, Mark. Very good additions, I think.
Can I just make a point around comms on the 111 service? So how are we going to get that message over to the public? Is that part of the winter plan?
It is out, yes, and I know it's now trying to be included within the broader NHS winter.
It's on social media news. It's out. It's a pretty strong brand, I think.
Okay, I'm going to quickly say Robert, and then I'll just go around the table. Robert?
Fantastic work. 2 quick questions. One is, as I'm sure you well know, if you have the misfortune to suffer from severe long-term mental illness, your lifespan is shortened by about 17 years. That's physical comorbidities mostly. So how well in place is the management of the physical comorbidities that these patients also suffer? As question 1. Question 2, in terms of detecting early relapse, wearables seem to be a promising technology to detect disturbed sleep patterns or movement disorders and so on. How widely are wearables being used to monitor these patients in the community?
Going around. Any other comments? Mark?
Just a general, to give us context, there's clearly a massive explosion in demand. At current rates, how does this roll forward? There's clearly capacity shortfall today. If it carries on, the demand grows at the rate it's growing today, where do we end up long term?
And if I had so that's that question. And if I had it's more of a comment, and it's going to be a rather silly comment, I think, but there are a couple of areas in here where you're going to do effectively a study, or we're going to roll out a pilot. It just struck me reading as a completely uneducated layman in this field that the evaluation periods look quite a long way away before we. So the question is, before we get to that end date, are we going to be taking any early learnings and trying to get, I'll call it quick wins or quicker interventions, or do we wait for the end of a 2-year evaluation before we then re-meet, or you then re-meet and then decide how you roll that out? So can we be faster than the paper's suggestion? I think there are 2 or 3 examples in here. They all seem very sensible. It's just the pace at which we would deliver an intervention. So do you want to have a go at those questions? That'd be great.
Okay, so in relation to physical health and mental disorders, you rightly say this is a real challenge. I'm in the very lucky position that I sit within the medical directorate rather than the mental health directorate, and I think it's been recognised by NHS England there's been a bit of a gap. Steve will know that when I go to any meeting, that when we talk about cancer, when we talk about respiratory, when we talk about cardiovascular, I always ask what are the programmes for those who have the greatest need and the poorest outcome, and often those patients, they're people with severe mental illness, and let's not forget learning disability and autism. There are health checks. The numbers have improved recently, but we're not at the level of health checks that we would like to have, and there's an additional push in order to move that forward. In terms of wearables, this is something of great interest to all of us. There are a huge number of people who are monitoring their own mental health using apps, looking at their own risk factors, accumulation of risk factors, and linking those to friends and family or even to care workers. There's a huge amount of work that we can do to further those sorts of approaches, and we do need to make sure that they are evidence-based. Now, the question about what will happen to demand, I think COVID did do something quite extraordinary in terms of demand, but we have also other pressures concerned about social media and particularly young people. And there are programmes looking to address that. So I think we have to hope that in terms of some of the prevention that we can actually do something about the ever-escalating levels. I don't think that anybody is suggesting that the demand will increase in the way that it has done. I couldn't say that that won't happen, but I don't suspect that it will carry on in the way that it has. But if you look at global disease burden, at the moment the global disease burden of mental illness is 23%. So of all, if you look at the overall impact of illnesses, so that's more than in cancer, it's more than cardiovascular. If we carry on in the same way globally, and in fact we're pretty well in the same position in the UK, the global disease burden will be 43% unless we can actually do something to reduce the demand. It partly goes up because of the success in other areas, and so we need to have the same sort of focus on prevention and early intervention in the mental health sector that perhaps we've had in other areas. And in relation to Chair's point about learning, I very much want to, we've set a 2-year timescale. I want to under-promise and over-deliver, but I'm aware that there are some real pinch points that we need to have something of value back. Key to this is the 10-year plan, and I think we, looking at timescales a week or so ago, there's probably a time in around March that we need to have something to come back, and I'd be optimistic that we will have something to say then. And then I think around early autumn next year, in terms of all the spending cycles, we will also need to have something back then as well. So I'm very much aware of that. I don't want to wait right to the very end, but I do want to make sure that we have a really proper evidence-based look at this, that we engage services, we engage service users, so we make sure that we get it right.
So can I just, I'm going to ask Duncan and Steve if they have any questions in a moment. Just before I do that, the only other aspect which I just felt slightly unnerved about at the end, reading the paper, it's where you talk about inpatient services and then wider service dependencies, and you're very clear about the challenge, and I'm prompted it because I know Mary Watkins, Baroness Watkins, has been asking very much on this point about available beds. And so what we see is we have 24,000 beds. I think it costs about 520 units of provision, I think, many of which I think are private sector provision. That's absolutely fine. But the issue is, and you alluded to in your opening remarks, it's running at a 95% capacity. And the question, I think, is how do we think about actually, because that doesn't seem at all a sort of a sustainable level at which to run. You've also got the staff shortages point, which are running at double the average in terms of vacancies. So pressure on mental health nurses and medics, so getting enough people trained and working in the system. And then just a paragraph on wider service dependencies. I mean, we don't disagree, but it actually sort of hangs out there in terms of many of these services themselves are struggling with funding and support. And so the question, I think, is how does one coordinate in this necessary multiplicity of agents working together in this space, or agencies, but actually many of whom are significantly, I think, under pressure and financial pressure. So when I read those, I was, I think you work in an area of real. It's not just that mental health is a real challenge, but actually in terms of the capacity to deliver service, it does remain a very challenging picture you give us. But you can either comment on that or ignore it. But I'm going to ask Duncan first, and then Steve, and then Vin very quickly to come through. So Duncan, do you have any reflections or questions?
Yeah, I mean, we've spoken about this before, but particularly the importance of learning and learning from the homicide reviews that happen and tragic cases when they. And I guess it's are we doing enough in that space? Is there more that collectively we can be doing across the NHS in terms of learning and taking action as a result of that learning?
And Steve?
No particular questions, because I think, Adrian, you covered it very comprehensively. But, but I'm delighted you like being in the medical directorate. But the serious point behind that was in appointing a medical director for mental health and neurodiversity, which is something we hadn't done before. We really wanted to, make sure that we had the most senior clinical medical leadership supporting Claire in the programme, but also to send a real message of just how important this area is to everything that we do in NHS England.
Thank you. Vin, you had a...
Yeah, thanks, Chair. So one's a question, actually, and then a couple of helpful comments, hopefully. So one is, in 3 local authorities across England, we will be piloting the digital NHS health check, which will be supported by blood-taking test kits at home. A bit like you can take a baby's blood spot rather than currently having to go and find a health professional to ask you the question. So if that's a value in looking at how that might particularly help rates of uptake of the health check in this particular population, I'd be really happy to work with you on that. The second piece is, I think, the future state vision for the app is eventually for it to be a place where NICE approved evidence-based apps could be recommended by practitioners, and again that's another area to look at, particularly if we've got ones coming down the pipeline, how we might start some innovation around them. And then finally, there's some really good products being developed in the Federated Data Platform in Cheshire and Merseyside ICB, so if you're not linked into those, I'll link you into those, because they might have helpful ways in which we might look at scaling those nationally if they're successful.
Thank you, Vin. So do you want to, those have last comments, and then we'll close that. Do you want to reflect on any of those comments or questions?
So in relation to beds and admission, nobody should be in hospital unless they really need to be in hospital. So we must always redouble our efforts to ensure that we have good community services, we have alternatives to admission, that we can manage crises at home. So we must, and I think the new models of care are quite exciting from that point of view. We must again get our target for early intervention, make sure that that's embedded. We intervene earlier, we know that outcomes are much better, so the need for admission is much reduced. We know that 10% of people in a mental health bed don't need to be there, they're ready for discharge. That's a very complex issue, often it is to do with resources in the community and particularly housing and suitable accommodation. So there are real things that we can do to address that. And yes, we have recognised centrally that in some areas we might need to tweak the number of beds so that we increase them. But beds is not the only answer to all of this, and it should always be the last resort. Really good to hear about digital health checks, and definitely we've arranged to meet to discuss a whole variety of issues, and of course the NICE apps. That's really good to hear. And in relation to learning, I think there are some great models out there. We need to make sure that we can spread that good practice, and I think that central group that's going to bring together a regional team, Aidan Fowler's team and our team, I think, and across both the Medical Directorate but also the Mental Health Directorate and Learning Disability Directorate, that I think there's an opportunity to really do something much more substantial.
Just to build, especially on your first question, Chair, around how we're managing 95% bed occupancy, there's a very important stat here where length of stay has risen from 40 days to 50 days since pre-COVID. So we've effectively lost 20% of our capacity. So we have to be managing that, and we've just been running a deep dive with our colleagues in the Department for Health and Social Care, precisely because we know a lot of those solutions sit outside of the NHS. So we want to go through that learning with them and think about what actions we can take at a national level that lean not just on NHS solutions but social care as well.
Thank you. So thank you very much for a very good paper and a very good presentation discussion. Really important area. And just to, I think, add, Adrian, you said in the introductory remarks that our thoughts with actually the families and friends of the three people who were murdered by Valdo Calacane, and so just to say, our thoughts are very much with those families. Okay, I think that just brings us to two last items on the board for today, and they're both starred items which are for information only. There's a paper which sets out the directions and mandatory requests, and it's a requirement for summary of all age continuing care directions 2024 given to NHS England by the Secretary of State. And then separately there's quite a list of the use of the seal, mainly Julian, I think it was all Julian actually, on a range of properties, often in mainly through primary care. But we should just note those uses of the seal. At which point, is there any other business? And can I thank everybody for both the private board this morning, very good board, and the public board this afternoon. Thank you very much.